Hello doctors. Today we are here with another topic of pediatric surgery, that is disorders of umbilicus in newborn. So before going directly into the umbilicus, we have to know few things about the embryology. So embryology, if you see the diagram, it looks complicated, but I will simplify this for you. So you have to remember few things. Number one, first you have to remember the yolk sac. This is the yolk sac, and yolk sac is present ventrally. Okay, then we have amnion. Amnion is present dorsally. Fine. Now the amnion, and here this is the chorion, and this chorion is the future placenta, and this amnion and chorion is connected by the connecting stalk. So remember this point very importantly. The amnion and chorion is connected by connecting stalk. Remember this. Number one, first important point. Second point, yolk sac is present ventrally, amnion is present dorsally. So yolk sac have two varieties. Either the yolk sac may be intracoelomic, that is inside, and the yolk sac may be extracoelomic. In my previous chapter, I have already told, in the 10th week of gestation, this intestinal loops goes inside, and if it doesn't goes inside, it causes omphalocele. So this when there is rapid division of intestine in 6th week of gestation, the intestine comes from yolk sac, from intracoelomic yolk sac to the extracoelomic yolk sac. Fine. So yolk sac may be intracoelomic or extracoelomic, and this intracoelomic yolk sac is connected to extracoelomic yolk sac by Vitteline duct, or which is also known as omphalomesenteric duct. Fine. So this is Vitteline duct or omphalomesenteric duct, very very important. So again I will repeat once again for you, very important. Amnion and chorion, which is placenta chorion, is connected by connecting stalk. Yolk sac is present ventrally, amnion is present dorsally. Yolk sac have two parts, intracoelomic and extracoelomic, and intracoelomic and extracoelomic are connected by Vitteline duct or omphalomesenteric duct. Generally, in normal neonate, by 5th to 7th week of gestation, this Vitteline duct gets obliterated. Fine. Now another thing we have to know is allantois. So what is allantois? Here we can see this is allantois. This is nothing but posterior wall of the yolk sac. This is the yolk sac. From the posterior wall of the yolk sac forms later on the allantois. Fine. And this is allantois. This is bladder. Fine, urinary bladder. And this allantois is generally rudiment in human. And this allantois and bladder is connected by urachus. Remember this point also. So remember this. Bladder and allantois gets connected via the urachus. Fine, we have three connecting system. One is the connecting stalk, then we have the Vitteline duct, and we have the urachus. And out of this, urachus is also present in umbilicus, and the Vitteline duct, if patent, is also opening is present in umbilicus. Now another thing which is important, here the previous diagram only this is. Here we can see the yolk sac, which was herniating in 6th week, goes back in 10th week, and as the age of the gestational age increases, this umbilical ring contraction completes by birth. This umbilical ring which you see in black color, this contraction is completed by birth. If there is persistence of this umbilical ring and it doesn't contract, then there will be umbilical hernia. Fine. So there will be a umbilical hernia if the umbilical ring doesn't contract by birth. Fine. Now this table is very very important, and MCQs will be asked and important for NEET SS exam. First, I have already mentioned urachus, connection between the allantois and the bladder. Generally, the urachus obliterates in normal individual, but if it doesn't obliterate, or if the remnant of urachus is present, this is the median umbilical ligament. So this is the median umbilical ligament from Urachus, very important. And if it doesn't obliterate, it will be patent Urachus, or there may be a sinus or cyst. Now we have the omphalomesenteric duct, that is vitalointestinal duct. Omphalomesenteric duct generally obliterates. If it doesn't obliterate, then it can form Meckel'S diverticulum or patent vitalointestinal duct or sinus, cyst, band or polyp. So Meckel'S diverticulum is a derivative of omphalomesenteric duct. Now we have the omphalomesenteric artery, which regresses and forms the celiac artery, superior mesenteric artery and inferior umbilicus. So if the omphalomesenteric artery does not regress, then in few of the patient we can find dominant artery which accompanies the Meckel'S diverticulum or fibrous band. Is over that area artery is present, that will be a dominant artery which supplies the Meckel'S diverticulum. And we have the omphalomesenteric vein. Omphalomesenteric vein forms the superior mesenteric vein and portal vein. And if it also persists, then it will also have a name, that is pre-duodenal portal vein, which is a derivative of omphalomesenteric vein. Now we have the umbilical artery, which generally obliterate, and remnant of umbilical artery is medial umbilical ligament. So we have the median umbilical ligament. This is median umbilical ligament, which is a derivative of remnant of Urachus, and we have the medial umbilical ligament, which is a remnant of umbilical artery. And we have umbilical vein. Remember, there is right and left umbilical vein. And right umbilical vein obliterates and left umbilical vein remains and returns the blood to IVC through the ductus venosus. And remnant of umbilical vein is falciform ligament. Fine. So you can remember this by left is left. That is, left is left out and right obliterates umbilical in cases of umbilical vein. So we all one thing you have to note very importantly, we have the median umbilical ligament from the Urachus, we have the medial umbilical ligament from the umbilical artery, and we have another, that is lateral umbilical ligament. Lateral umbilical ligament is a derivative of inferior epigastric artery. You have to remember that also. Now, when the baby delivers, you can see that in the stomach, in the abdomen, we have the umbilicus and cord is attached to it. And this cord is, time of separation is 3 days to 2 months. This is sometimes asked, which is after delivery. Now, function of umbilicus. First, we have to know the function of umbilicus. Function of umbilicus in children, it is easy to do vascular access for catheterization is done, umbilical catheterization for vascular access. Number second is portal of entry for most of the laparoscopic procedure. In laparoscopic, we insert the port in umbilicus in children. Now, then it can be a conduit for intestinal and urinary, because cosmetically it is superior when it is closed. So intestinal, either stoma or urinary conduit may be created in the umbilicus. It has an aesthetic value and it is in uteroportal, because umbilicus is while gestation, umbilicus is related to the portal vein. Fine. The normal location of umbilicus is L3 and L4 behind vertebral level, and at the level of the iliac crest, umbilicus is present. Remember this also. Now, umbilical abnormality. Umbilical abnormality can be acquired or congenital. Acquired abnormality is umbilical granuloma and umbilical infection. And congenital is omphalomesenteric remnants, urachal remnants and umbilical dysmorphology. Remember these two categories. Before going into the acquired, I will just tell you the vital and intestinal duct abnormalities. Number one, as you know, vital intestinal duct is a connection between the intra and extracoelomic of the yolk sac. But as the child, when there is time of birth, it means that the intestine, this is the intestine and this is the umbilicus, and this is connected by the vitalointestinal duct. If it is fully patent, then it will be Vitteline fistula. If the mid portion of the Vitteline duct is persisting, then it will create a cyst. This is also known as umbilical cyst. Then it can be a remnant in case and present like a cord structure. This is a cord structure. And if the distal portion gets obliterated but proximal portion is present, then it forms the Meckel'S diverticulum. Remember this, very important, always asked. And while we do appendectomy, we always check for Meckel'S diverticulum. As you know, rule of 2, it is also present in 2% of population. And out of all this abnormality, most common is Meckel'S diverticulum. And it can also persist as Meckel'S diverticulum and a Vitteline cord. So these are the abnormalities of the Vitteline duct. Normally the Vitteline duct gets obliterated. Now we will start with the acquired condition. We have the acquired condition. Acquired condition, we will start with the umbilical granuloma. Now umbilical granuloma is after the cord separation. When the cord separation means cord have detached from the umbilicus after birth, then after cord separation we can see some granuloma like this. And it present as a small mass. It present as a small mass of granulation tissue at the base, and there is abundant fibroblast and abundant capillaries in this area, and sometimes bloody and watery discharge is also present. Treatment on this, either we can do silver nitrate, we can apply silver nitrate, then the granulation tissue gets destroyed and it heals, or if topical application is not enough, we can do electrocauterization for this umbilical granuloma. Now we have the umbilical infection. Umbilical infection is, why this occurs? This is because of poor hygiene. This occurs because of poor hygiene. Proper hand washing should be done while touching the baby, and all this care should be needed. And this is caused, infection is caused due to mainly by Streptococcus aureus and Streptococcus pyogenes and Staphylococcus aureus. And there may be cellulitis in the region of the umbilicus, and which will might progress into necrotizing fasciitis if ignored, and with signs of neonatal sepsis. After later on they will present with the signs of neonatal sepsis, and these children require hospital admission, and later on if it progresses further, then it will cause umbilical gangrene. And as I have told earlier also, that the umbilicus is related to portal vein in the child, because the umbilical vein the left umbilical vein remains and forms the ductus venosus, and IVC and portal veins are related to that. So umbilical sepsis might cause EHPVO. EHPVO is what is EHPVO? EHPVO is extrahepatic portal vein obstruction. So these are the two acquired condition of umbilical abnormality. We have the umbilical granuloma and we have the umbilical infection. Now, omphalomesenteric remnant. This is a congenital abnormality of umbilicus. Omphalomesenteric remnant, either we can have a patent vital intestinal duct, then we will have a feculent discharge from the umbilicus, or there may be prolapse of proximal or distal ileum from the umbilicus, and small fleshy mass can be seen over the umbilical pit. How will you be sure of it? We can do, if this is the child and we have the umbilicus here. In the umbilicus, if there is only big fleshy mass and opening is present, but you are not sure whether the fecal discharge is coming out from the umbilicus or not, then we generally take a infant feeding tube. We take a infant feeding tube, narrow infant feeding tube, and we insert into the opening of umbilicus. Where the opening is present in the umbilicus, we insert an infant feeding tube inside the umbilicus. And one thing is that the infant feeding tube goes easily inside the umbilical opening, and when we take out the infant feeding tube, we will see fecal stain in the infant feeding tube, by which we are sure that there is a patent vital intestinal duct. This is a clinical diagnosis. Then it can present as a sinus also, it can present as an umbilical polyp, and umbilical cyst is, I have already told, mid portion of the vital or intestinal duct remains patent, and on and off discharge is present, and treatment is excision. excision, we give an infra-umbilical incision and we excise the whole tract along with the cyst. Now, we have the urachal remnant. Urachus is present in between the allantois and the bladder. So, in case of this, there is a clear drainage from the umbilicus, not fecal. This will be clear because this is attached to the urinary bladder. So, peri-umbilical excoriation may be present and urinificus smell around the umbilicus will present, and pain while there may be pain while micturating. Around the umbilicus there will be pain while micturating, and diagnosis is also clinical. We can do CT, MRI and USG for further investigation, and treatment is here also we give an infraumbilical incision and tract is removed. Okay, now what are the tumors from the urachus? Generally, when there is persistence of urachus, it may be associated with, most common is adenocarcinoma. Apart from that, there can be transitional carcinoma, squamous cell carcinoma, mucinous adenocarcinoma, malignant fibrous histiocytoma, fibrosarcoma, pleomorphic sarcoma, and York-sac tumor can arise from the urachus if not treated, and later on can present as a tumor. Now, umbilical dysmorphology. We have covered two topics of the congenital abnormality of umbilicus. Now, the third one is umbilical dysmorphology. Umbilical, this happens because generally there is only single umbilical artery. Always remember there is two umbilical arteries present. So, if there is single umbilical artery, there may be umbilical dysmorphology. And there are few conditions like, number one, we have the Robinow syndrome. In Robinow syndrome, there is high umbilicus, means umbilicus is present up to the sternum. This is known as Robinow umbilicus. Then we have the Rager syndrome. Rager syndrome is big, fleshy and redundant umbilicus. There will be a big, fleshy and red umbilicus is present with redundant skin may be present around it. That is Rager's syndrome. Then we have the Urachus syndrome. That is, we have a flat umbilicus, not everted or inverted. We just have a flat umbilicus. So these are the dysmorphology of umbilicus, which is also a congenital abnormality. Now, another important thing that you have to remember is I have made a differentiation so that you can remember easily, because people get confused in between these two terms. One is the umbilical hernia, another one is hernia of umbilical cord. What is umbilical hernia? Umbilical hernia is defect in linea alba because of the weakness of the dense facial ring around the umbilicus. But remember, in umbilical hernia, peritoneum is intact. There is no defect in peritoneum. Defect is present in linea alba, or weakness is present in dense facial ring, but there is intact peritoneum in cases of umbilical hernia. But in case of hernia of umbilical cord, there is defect in the peritoneum. There is defect in the peritoneum along with the defect in the fascia. So this is also known as small omphalocele, hernia of umbilical cord, and intestine herniate into the substance of the umbilical cord. And in this case, you have very important, in cases of umbilical hernia is more common in Africans and male equal to female, like boys and girls have equal ratio. And this undergoes spontaneous closure, unlike in cases of inguinal hernia or in cases of epigastric hernia, surgery is needed to repair this. But this is the only hernia in child, which is umbilical hernia, which doesn't need a surgical closure. 80% of umbilical hernia resolves spontaneously by 3 or 4 years of life. And if there is intestinal obstruction or perforation or strangulation is present in the intestine due to hernia, then only we do the surgery. But 80% of umbilical hernia resolves spontaneously or spontaneously closes. But in cases of hernia of umbilical cord, as we have the defect in the peritoneum, we need to do surgical closure in cases of hernia of umbilical cord. So remember these two differences in between hernia of umbilical cord and umbilical hernia. So I guess this is interesting for you. Thank you for watching, guys. Please do like, share and subscribe to my channel so that I can make more free videos for you guys. Thank you.